Hi, this is Sue Piché again, and welcome if you're joining me for the first time, or welcome back if you've been following the series. So this is the Menopause Mondays, and this is part 3, and we're going to focus on hormone replacement therapy this time, the pros and the cons, and how apropos, because today is World Menopause Day. So when we started out looking at stages and definitions. Basically, just the first bit was covering the signs and symptoms that you might be expecting. And then we went to part 2 and we looked at the non-hormonal things that you can do or choose to do in your journey in the menopause transition. And now we're going to hit part 3, which is focusing on the hormones and disease comorbidity, because this is when I usually get those questions. And coincidentally, these are the comorbidities that we're going to be looking at. So osteoporosis, breast cancer, little caveat on uterine cancer too, heart disease. And these are the top 3. These are the top 3 culprits that everybody wants to know about. And again, apropos, because today is World Menopause Day or month, depending on where you are. They say it's World Menopause Month, and this year's theme is bone health. And World Osteoporosis Day is 2 days from now. And of course, October is Breast Cancer Month, Breast Cancer Awareness Month. You can wear pink all this month if you want, and that's fine. Heart disease falls in February, but that's okay because we can still talk about it in October. That's good. So remember back when we first started talking about this, we started talking about the hormones that are the top ones in our transition. Those are estrogen, progesterone, and testosterone, and they fluctuate back and forth to affect us whether we have an excess or a deficit, and thereby they affect the number of different health concerns that we have to deal with. And more specifically, in part 2, we discussed vasomotor symptoms, and these are the cardinal symptoms that affect 60 to 80% of midlife women. And they're not fully understood, but it seems that the estrogen fluctuations affect the vasomotor center governing blood pressure, control of cardiac function through their vasodilation and constriction. So in turn, that affects the hypothalamus and your body temperature regulator. So it causes that havoc that we're most familiar with. According to evidence-based research, I just want to point out that here is where we really want to emphasize it. Hormone therapy is the gold standard to manage your vasomotor symptoms. But before we get into all that hormone soup, what I want to do is remind you about another theme that I've sort of keep bringing up, and that's the placebo and nocebo effect. So when regardless of which treatment path you choose to follow, whether you believe it will work, the placebo effect, or whether you believe it won't work, the nocebo effect, your beliefs contribute to the outcome of your choices. Hormone therapy, like anything else, is linked to this effect. However, I'm going to be showing you also facts that have come from studies that indicate whether you believe in it or not, the studies show that the effects of hormone therapy does reduce vasomotor symptoms. So often women, state that they don't like the idea of taking hormones because they don't like taking medications. So I just wanted to point out that hormone therapy is a process of supplementation. It's a therapy that provides your body with some replacement or a supplement of hormone or hormones that your body's had. And you've had this for your whole life, and it's not putting something foreign into your body. You're supplementing a depletion. So much like if you were iron deficient and you went to the doctor and the doctor told you to take some iron supplements, you would say, okay. And you probably wouldn't question that so much. But we find that women more often question this type of supplementation with hormones than anything else. So I just want you to wrap your head around that concept. In the picture here, the dark colors, the dark purpley colors, are the hormones. So you begin to get hormones, you get them to even out. That's the normal, typical routine. And that's what we're definitely talking about in this series. But once you get beyond a certain age, those hormones start to decrease. So the little HT there is representing how you would start taking hormone therapy. And what it would do is even out that time period so that then you would take it to a level that you can cope with. And then in the ideal situation with your healthcare provider, you discuss when you might want to go lower. So this is a thing that always comes up. What is natural? So I've taken some of this video that Dr. Barbara Taylor is a gynecologist from the US, and she's also known as Menopause Barbie. So I recommended her stuff to you. She's got many YouTube videos, but she's also got a plethora of information on her website as well. But she takes some getting used to. But I like the way that she explains this. So without further ado.
First, let's look at the strict definition of natural. So by definition, natural means a substance found in nature that we utilize in its original form. So obviously, this definition would include a plant that has hormonal properties or effects. It would include parts of a plant that are pulverized or powdered. So here's turmeric powder. It would include an herb in its natural form or compressed into a tablet like these donne tablets. And I'm sure you're with me so far, right? Because so far I've only included plants and herbs. And you think of them as naturally.
So she points out some really important things, that the way that we think of natural, and I'm going to talk a little bit more about semantics as we move through this process, but I really need everybody to kind of be on the same page. So further the discussion. So we've got the plants are natural, and I'm pretty sure we can all agree on that. Are animals?
Now, what if I said that a natural pharmaceutical product of either plant or animal origin could be natural? Are you balking at that? Do you think of plants as natural and animals as unnatural? No, of course they're natural. Do you think something has to come directly from the earth to qualify as natural? The word natural comes from the word nature, and animals are found in nature. And if animals aren't natural, are they synthetic or artificial? Well, of course not. So, what about animal products? Is an egg from a chicken natural? Is honey from a bee natural? Is the urine from a horse natural? You probably think I'm crazy with the urine from a horse, but is an animal product natural? What if it's been in a lab? What if its state of origin has been changed? Okay, let's say it was found in nature in liquid form and then converted to a solid in the lab. Does that make it unnatural? See, I wasn't being goofy when I asked you about the urine of a horse. An example is a product called Premarin, comes in both pill and cream form, that is nothing more than horse urine. And it's one of the best-selling menopausal products of all time. Premarin stands for pregnant mare urine.
So just keep these thoughts in mind about the semantics of natural, because as a healthcare provider, and that's of course what we're gearing for when you finally end up going to your healthcare provider and how you're going to communicate your wants and your needs. And also to identify to yourself first what your wants and needs are. So you might have to ask yourself some of these questions, like, what do you consider natural? So this one might be a little more familiar to you. So hormone therapy in younger women is birth control pill. BCPs are a hormone therapy. And it's often prescribed for a number of different reasons. And all those reasons, the premenstrual syndrome, the premenstrual dysphoric disorder, basically it helps decrease bloating, headaches, controls moodiness, anxiety, depression, et cetera. And it's prescribed for so many things, as well as, of course, the thing that it was made for initially was to prevent pregnancy. But note that a lot of these symptoms are repeated in the menopause transition. So you can see how hormone therapy can help with the menopause transition. This BCP therapy is accepted as treatment in young women, and they often stay on this treatment for years without question or judgment, unlike hormone therapy for menopause. So just something to keep in mind. So why consider hormone therapy? Well, like we've just discussed, it can help you with the vasomotor symptoms. It's the treatment that has the most scientific support behind it. It's natural. Again, depending on what your semantics are of natural, but it is natural to your body. And it means that it's derived from plants or animals and processed through a lab. So the term natural can be debated, of course, but again, something for you to think about. The benefits outweigh the risks. And that, again, is also something personal for you, but very often this is why people tend to turn towards it. And there's a number of studies that have been done that, of course, hormone therapy decreases severity and frequency of hot flashes, so for your vasomotor symptoms, but it improves sleep, mood, urinary symptoms, because it also repairs those tissues in the vaginal canal. But the other thing that really we're starting to focus on now with a lot of studies, it's been in the last, I would say 5 years, they're really starting to look at it, is deterioration of cognitive abilities. And they used to connect this with estrogen depletion. There is no firm studies that can confirm or deny this, but they can confirm that it doesn't hurt. So that taking the hormone therapy does not deteriorate your cognitive abilities, which is a bonus that we at least know that. So we've talked about natural. So let's talk about synthetics, because this is often the pushback that women get to. Like, I don't want to take medications. I want to take something natural. I don't want to take something synthetic. That's the kind of information that we tend to hear as healthcare providers. So again, I'm going to lean on Dr. Barbara Taylor to give us her insight, because it's nice and simple and straightforward. Oh, if I can get her going.
So now what comes to mind when you hear the word synthetic? Are you thinking artificial, fake, poorer quality, unnatural, not from the earth? Well, here's the actual definition. Synthetic is a product which results from combining substances together. So the word synthetic focuses on how the product was created, not on the origin of its components. When you go in your kitchen and cook and you mix ingredients together, you're synthesizing something. So if I take walnuts cashews, and almonds, and I mix them all together so that I have a nut mixture. Okay, there's my nut mixture. They're all in there together. What do I have? You see, the word synthetic comes from the word synthesis, so it means to create something. But that only addresses the process. It doesn't address the nature of the product. So, is my nut mixture still natural? Does the fact that I mix them together mean that they're no longer natural? Does the mixing make them synthetic?
So, again, something to think about. So let's talk about now bioidentical. And I'm not sure whether anyone's been introduced to bioidentical hormones before, but they are increasing in popularity. So let's just get a little grip on what we're talking about with regards to that terminology. Whoop. All right.
Would you think I'd gone completely bonkers if I told you that natural may also refer to something that is of neither plant nor animal origin and is not even found in nature? Well, have you heard of bioidentical hormones? Most people consider them natural. Are they? Well, let me tell you a little bit more about them. The definition of bioidentical is a substance made with molecules which are identical to the molecules in the human body. So they're of neither plant nor animal origin, and they're not found in nature. So this is trieste, which is a bioidentical estrogen. But bioidentical hormones are more similar to your own molecules. So does that make them more natural or less natural in your opinion? You see, remember, this is all about you. Your opinion is the one that matters here.
Yeah, I completely agree. Your opinion is the one that matters. So when we look at hormone replacement or supplement therapy, you're looking at a number of different forms, natural, synthetic, or bioidentical. So now we've got kind of a concept of what those different forms are, but then get into the nitty gritty of it, and you can see there's other forms that you can utilize. And these forms of the medication, if we're going to call it a medication or hormone therapy, if you will, depends on your symptoms. So you might prefer an oral or transdermal, a patch. You might prefer vaginal preparations. You might prefer foam, gel. So it comes in a variety of options. And those options are what you need to tell your health practitioner when you're discussing whether you want hormone therapy or not. You need to discuss what options or route you like to deliver your hormone therapy, because it's very personal. It's quite a personal choice. If you can take a pill every day, that's great. Not everybody can. And the patches, well, if you work out every day and you're taking, a couple of showers a day, the problem with the patch staying on sometimes is quite irritating. So think through some of those things when you're deciding on what route you'd like to take. So with regards to estrogen, we're going to talk about how estrogen and progesterone go together hand in hand. And this is Chrissy Rowan from the Canadian Nurses Association. She's a nurse practitioner, and she's just going to do a little blurb on that issue. Whoop. Oh boy, a little quick.
Estrogen use alone places women at risk for endometrial hyperplasia and cancer. So women with a uterus need to have some endometrial protection using either progestin therapy or basidoxifene. Women without a uterus don't need to have any endometrial protection. They can use estrogen therapy alone.
Okay, so hopefully what you got from that blurb was that if you have a uterus, you have to have progesterone. So when you're looking at your hormone therapy options, you want to pick the right kind of device or route for you. And as you can see, there's a number of different choices that you have. This table isn't completely everything that there is out there, but it's one that I got from the Society of Obstetricians and Gynecologists of Canada. And if you were prescribed any of these based on your needs, signs and symptoms, or circumstances, you can see that there's multiple dose levels, so different strengths, and there's oral or transdermal products. If you were to try all of these, taking each for a 3-month trial period, you wouldn't be able to get through them for like 10 years. So that's why it's important to be able to discuss your needs and your wants with your healthcare provider to try to narrow things down, which would be the best route for you. So, what are the reasons to consider hormone therapy? So we've talked about these, and we know that these are some of the reasons that'll work. And now we also know that treatment delivery options can be individualized for you. So it's whatever works best for you. But let's get into some of the big questions that people always come to me with. What are some of the risks? So this is the big one. This is the big one that everybody asks about, including healthcare providers. They will ask you whether you're worried about this. So this slide is just to talk about absolute risks with regards to aging. So honestly, it depends on an individualized situation analysis, meaning you need to discuss with your healthcare provider and look at your specific risks, whether you have anybody in your family and how close that family member was to you, whether you've been exposed to anything in the environment, those kind of things, et cetera, et cetera. So, but I'm going to just give you a few points with this, and then I'm also going to give you some links. So whether you take hormones or not, okay, so just normal aging, this is how your risks go up, this little list of stats here. So the scary thing is that just living, if you're a woman and you're living, the older you get, the increased risk you get of breast cancer. Doesn't matter what you do. Now, you know, we factor in all kinds of other stuff when we look at someone's individual risk, but this is just an absolute risk based on a big population of like women. So according to the Breast Cancer Organization, the relative risk increases up to 75% if you're taking a combo hormone therapy. So that means an estrogen progesterone, but don't panic, okay? Because they've put out a booklet, Think Pink, Live Green, and I'm going to include that booklet in our follow-up, but you can always go to their site and download it. It's a great little booklet, and it makes you think about breasts through a whole life perspective. So not just menopause, but things that we've done when we're younger, and that how they might have an impact now on our life. And if you have daughters or you have younger girls in your circle of friends, this booklet is a must read. It's just nice and straightforward and gives you that information. But don't worry about that increase of 75% right now, because we're going to go on and look at some other things first. But I just want you to get the idea that the risk is for every woman who grows older. So if you decide to do non-hormonal therapy, you are still at risk for breast cancer. So you still need to be aware. Now, we talked about how I didn't want you to get too upset about that increase of 75%, because if you look at statistics, they can be skewed in certain ways. So that 75% has to do with a large portion of people, and it's not specifically targeting a group. Once they, in the breastcancer.org link, this particular link that I've given you here, they explain how they've figured out that it's actually a 0.08% when estrogen and progesterone are used. And that only gets up that high after you've used it for 5 years. So that's 75%, because of course, they're an organization that wants to try to tell women to be aware of risks. So they want to caution women. So they put the bad stuff out front. And that's fair. That's what they're there for. But once they get into the nitty-gritty of it and you dissect some of this stuff, you start to realize, okay, it's not as bad as I think it is. So actually, your absolute risk, so remember that last slide, your absolute risk depends on what your age group is, and you have an absolute risk based on just how old you are, times your relative risk, and that's the 0.08%, equals your risk over a lifetime. So when you start thinking about those numbers, they're not quite as bad as you may have previously thought. They're also not quite as bad as some statistics will lead you to believe when they're lumping a whole bunch of things together. So again, if you started after menopause, there's been so many studies done that there's no risks even after 10 years of treatment. So there's no difference in the risk factor. And if you're only taking estrogen, there's actually no risk. So those women out there, for example, we had a woman last year on this series who had an ovary removed and the other ovary wasn't functioning properly. So she was into menopause early, so because of surgical circumstances. Well, because she didn't have a uterus, she didn't have to take progesterone. So for her, actually, just having the estrogen, she could easily make the choice to go on estrogen, and it didn't feel like as much as a risk for her because it's not. So you have to think about what your particular circumstance is. I'll always come back to that. It has to be individualized. So the big thing here is where I had to add, with our lifestyle choices, I had to add environmental toxins. And of course, one of the environmental toxins that we're often introduced to is alcohol. So these are the statistics. So your relative risk increases to 50% in women who drink 2 alcoholic beverages a day. Now, that being said, you have to dissect that material and think, okay, well, what they did was they studied women who had 2 drinks a day compared to women who didn't drink any. So that doesn't mean that if you have 2 drinks today, you're not going to increase your breast cancer by 50% that particular day. This is a long-term thing. So just to make you understand that when you read through some of these statistics, you have to look at where they came from and how they're generated, what kind of studies they did, and how they're breaking it down. So, and just a little tidbit, if you've had a breast reduction, depending on which reference material you read, but on average, you have a 30% less risk overall, even including your absolute risk of breast cancer concerns. So anybody who's had a reduction for whatever reason, you can sit back and relax a lot more than anyone else. So I've added a couple tools here, like I said, so that you can do your own at-home standardized assessment, but this doesn't replace you sitting with your healthcare provider and discussing them, but it'll give you an idea of things that you have to accept in your own life. your genetics, stuff like that, things that you've been exposed to when you were a child, or maybe in a job that you worked at. So things that you can't change and things that you can. And that can help you mitigate your risks for breast cancer. And I like both of these sites. They're both bilingual. The first one from Ontario is French and English, and the US one is English Spanish. So I'm including this slide just because I always get the questions. So here's the most biggest important thing is your best bet is to get to know your breasts. Do your own self-exams regularly. Find out what they feel like and do it often enough that you can tell when there's changes. Have a regular mammogram. If you have any risks in your background, a regular mammogram is where things might show up that you can't pick up on a self-exam. And just for your interest, there's symptoms of breast cancer here. So these are the kind of things that you would look for as symptoms of breast cancer, but very often we get breast discomfort when we're going through any of our female transitions, when you're going from puberty into adulthood, when you're going into pregnancy and out of pregnancy, when you're going into menopause and into postmenopause. When you go through each of these transitions, you can get breast discomfort, and many women do. So take a little self-assessment and say to yourself, is this discomfort like a normal cyclic discomfort, which is due to my hormone fluctuations? Or is this non-cyclic? Is it something that's happening and potentially due to non-cancerous causes? Like maybe I've got an infection, maybe I've had some trauma, hit myself, maybe I'm taking some medications that can cause bloating or swelling in my breasts. Or maybe something's happening with supportive tissue, like your muscles that sit on your chest wall or your ribs. So I just want you to be aware of this, because I very often get the question, we got it last year, about breast discomfort and breast pain. So breast pain is rarely a symptom of cancer. And if you want to know more about it, there is a link here. And of course, prevention, that whole lifestyle stuff. I'm not going to preach it here, but I am going to say it again, because it's the most important thing to help you through your menopause transition. And again, breast pain is rarely a symptom of cancer. So how about uterine cancer? Because we always talk about breast cancer, but uterine cancer is actually just as important to be aware of. And if you're taking progesterone because you have a uterus, and you must take progesterone if you have a uterus. Progesterone is one of those hormones that is in your body because it's there to make the baby home more livable. So progesterone is there to build your uterus up nice. And so we have it in our system for that particular reason. But if you don't have a uterus, then you absolutely do not need progesterone. And if you do not need progesterone, then you shouldn't be taking it. And your healthcare provider should understand that and give you just estrogen. And again, that decreases your chances of breast cancer. You don't have to worry about it. And you don't have to worry about your uterine cancer. But here's what I have to say. Even though the number one question always seems to be breast cancer, heart disease is really a very important question that we need to deal with. So 1 of 2 postmenopausal women will die of a heart attack. Just let that sink in a little bit. Heart attacks will kill twice as many females, twice as many as all cancers combined. So this is something to be quite serious about, and especially if you've got some family history or you've had some cardiovascular incidents for whatever reason. Again, environmental exposure is such a big thing nowadays. The toxins in our environment cause a lot of problems. So here's where you might want to look at hormone therapy as something that will help prevent heart disease. So no offense to any of you, but I have a lot of heart disease in my family. And if it's 1 out of 2 people, I'm kind of hoping that it's going to be you that has the cardiovascular issue and not me. So I'm more inclined to look at hormone therapy simply as a deterrent for heart disease. Because remember, we talked about how vasomotor symptoms are helped because the estrogen works on the walls of the vessels, vasodilation, vasoconstriction. So it helps to deal with some of those issues from heart disease. Now, the only thing that then becomes an issue, which people don't talk about much at all, like I honestly, I've actually brought it up to my physician when we talk about estrogen and any hormone therapy. There's always discussion about breast disease and not so much about thrombosis. But your risk of getting a clot if you're taking an oral estrogen or oral estrogen and progesterone tablet, your increase of a clot is really high, and it gets higher and higher and higher the longer you're on that medication. So what you want to do is you want to make sure that you change it over from an oral medication to a patch as soon as you're comfortable and able to do that. And again, I'm going to top it all off with prevention, all that lifestyle stuff again, the most important thing. And osteoporosis being 2 days from now, our International Osteoporosis Day. I want to make sure that you're very aware of this because 1/4 of women over 50 have osteoporosis, and those are the ones that are tested. So I can tell you there's a whole lot more that probably aren't tested that have it. And I tell all of the women that I talk to, get a bone density scan. It is so important. And your healthcare provider will not offer it to you, and unless you've had a fracture, and then they'll insist on it. And that's what very often happens, is that osteoporosis is discovered when someone has a fracture. And by then, that's when the damage is done and it's too late. So if you can discover osteopenia, which is basically, if you compare it to diabetes, you want to find out whether you're hyperglycemic, and then you can do something about it before you're full on diagnosed with diabetes. So this is the same thing with osteoporosis. You want to find out if you're osteopenia before you're full on diagnosed with osteoporosis, because then the treatment is a whole different thing. But estrogen helps to maintain bone density. So again, another reason why you may want to consider hormone therapy, because as your estrogen decreases, your bone density decreases. And I want to make sure you understand the difference between density and strength. Estrogen loss equals bone density loss. Now you can have all the calcium and vitamin D that you can possibly get into your body, and it is not going to help you with your bone density, but it will help you with your bone strength. So it's important. Absolutely, it's important. And you want to make sure that you get your calcium and your vitamin D, and that you want to stay active. And preferably, if you can add some weight training into any activity program, weight training helps to strengthen your bones. So that is all what you should be doing in order to maintain the strength of your bones. Now, if you've already had some bone density loss, then that's key. That is key to keeping you good and healthy and not putting you in a fracture risk category, is that you want to keep them strong. So you can read through this little list on your own time, sort of thing. But basically, in a nutshell, that's what I want to get through to you. Bone density is built up before the age of 30, and you want to keep what you build. So that bone density that you've built up in your younger years, and a lot of people don't understand this until they're well past the age of 30, that you can't build up any more density. You can work all you want when you're 40 years old, and you are not going to get any more density in those bones, but you can strengthen them. So that's key, making sure that you keep them strong as you grow older. And get a bone density scan. I can't say that enough. It's sad to say, but everybody that I've sent for a bone density scan has come back and told me they're either osteopenia or osteoporosis. And these are women who are in that perimenopause stage. And it's really sad that it's not something that we currently test for on a routine basis. At least now with mammograms. Mammograms are usually done once every 2 years, as long as you're clear, after the age of 50. So it depends on the country that you're in, but at least breast cancer, we kind of have covered and we keep up on that, but osteoporosis, we don't. And it's such a debilitating disease. If you get a fracture, it can really cause a lot of havoc in your life. So get a bone density scan. It's important. So how do you prevent it? It's back to that whole thing again, all those lifestyle choices. So we won't go through this. We already talked about this when we were discussing what to do in part 1. So, but you can see how it keeps coming up. So this is a theme and you need to pay attention to it. So heart disease prevention, hormone therapy and disease prevention, not just heart disease, but heart disease, osteoporosis, and breast cancer. Now, breast cancer will go up no matter what. So the hormone therapy doesn't do anything to help your breast cancer. So that is the only one that you need to be really on top of, and you need to get an individual assessment done. But diseases that you can help with hormone therapy are your heart disease and osteoporosis, and some of those other signs and symptoms. So you have to make sure that you take the right dosage in order to help with disease prevention, if that's what you want to do. Maybe you only just want your vasomotor symptoms to disappear. So there are different strengths of these hormones. So just keep in mind what you want. Remember, I said what you need to do is figure out your wants as well as what you need. So your wants are important. Do you want it to be natural and what you think is natural? Do you want it to deal with just what's going on with your genitourinary system? And if so, then you can do something that's a cream or a vaginal ring or an insert, like an IUD that works more on your vaginal lining as opposed to a systemic hormone therapy. So hormone therapy, why? Why consider this as an option? So we talked about the vasomotor symptoms. We talked about treatment delivery options, that there are many that you can choose from. And now what we've really looked at is disease prevention and health improvement. If it's given within 10 years of menopause, it's shown to prevent bone loss, decrease fractures, and decrease cardiovascular issues. So there's a whole lot of information and research studies that show this is the case. There is now research that's coming out that says that Hormone therapy also helps with cognition, meaning specifically the research is focusing on dementia and Alzheimer's. There is no firm evidence right now, but is certainly a thing that scientists are talking about a lot. And you will hear your health practitioner, yours or many, or other people within the community saying that you can only be on hormone therapy for 5 years. So there are firm research studies out there that say, no, there's no mandatory stop date. So don't think like I have women who've actually made decisions that, okay, you know what, if I can only stay on it for 5 years, then I'm not going to do it because I can just ride through this and it'll probably be over in 5 years. Now we know from what we talked about earlier, this can last. This can last up to 10 years. And post menopause, you can still have a lot of these symptoms. So this is something to really consider. So we're back to Chrissy again, and she's just going to talk to us about screening.
No special investigations need to be conducted prior to initiation of therapy. A complete history and physical should take place. Consideration should be given to women with unexplained vaginal bleeding, any current active estrogen-sensitive cancers like breast cancer or endometrial cancer, liver disease, coronary artery disease, stroke, or VTE should be contraindications to hormone therapy. No screening needs to be completed for breast cancer or colon cancer prior to initiating therapy.
Okay, thank you, Chrissy. So what Chrissy said is basically on this particular slide right here. Why not hormone therapy? And this is why not. If you have any of these contraindications, you should not be taking hormone therapy or only taking hormone therapy with strict oversight from your healthcare provider. Now, that being said, I'll say the one thing that's the number one most important why you shouldn't take hormone therapy is if you don't want to. If you don't want to take this for whatever reason, then don't. Because you know what? You shouldn't be pushed into any kind of treatment or therapy. If it's not going to make you happy, then it's not going to make you happy. So, takeaway points. We talked about getting a map. So, that idea of getting a map is very symbolic. And you know that. What I want you to do is go out, talk to people. So you find out the route that you're going to be taking. Talk to other people who've been through it. Find out some information. Look at what you should expect. Will the road be bumpy? Will it be smooth? What are my options? Where can I turn? Where can I not turn? And then track your route. So if you're starting to have signs and symptoms, keep records of them. And I often say this to younger women as well, because your periods when you're younger are very significant, because I'll tell you, when you get to be older and that physician or nurse practitioner or whoever asks you the question, have your periods always been like this? Sometimes you just sit there and go, I'm not sure. I can't remember. And so I tell younger women as well, it's important to look at your periods all through your life. Don't just start when you think you're perimenopausal, just start. Start whenever you can. And compare your options. So I'm giving you a lot of information, and I'm giving you a lot of links to sites where you can go and look yourself, because of course this is a vast topic. But really what I want you to do is to find out what your options are, make your decisions based on what you have going on in your own body and what your tolerances are, what your ill effects could be. So basically, you weigh your own risks and benefits. You want to make sure that whatever you're taking is safe. You want to base it on solid research, and you want to have your own team. You are in charge of the team. Your healthcare provider is one of your team members. So next week, we're going to wrap up this whole discussion with regards to how to deal with your healthcare provider based on kind of what we've already done, tracking symptoms and everything along the way. So we'll talk about that more next week. And I always like to leave off with contact information. So your number one contact information is your local provider, because if something happens, you want local follow-up. So it's wherever you happen to be in the world, it would be ideal if you had a provider there. Now, they might not always speak your language. It might be a little awkward. So you know that if you are a military member or part of a military family, that you are supported by the Guyland-Kirschen Medical Clinic. And these are the important numbers that you need to have. I am always welcome for fielding questions. I will help direct you in the right direction for any kind of information you need or kind of research you need to be looking at. So by all means, contact me if you need to. And other than that, I hope this webinar has been informative, and I welcome any questions. We're going to open up things for the floor, and hope you can join me next week. Thank you so much.